Well, thank you for showing up and after lunch. Next slide, please. I have no relevant financial relationships. Your trivia for today is that in addition to many other saints and many other things that Saint Valentine is responsible for, Saint Valentine is the patron saint of epilepsy. Next slide, please. All right, so, what I wanted to go over today was to really talk about epilepsy because both among care providers and also among families, there's a lot of misunderstandings, misconceptions, kind of old understandings of what epilepsy and seizures are that can lead to delays in care or, and then really it's delays in care or inappropriate, approaches to care that we're really hoping to improve. Because, some of the greatest advances that we have in the treatment of epilepsy actually are surgical, which you'll be hearing about next. But in my opinion, if we do not find the patients that actually would benefit from surgery, then it doesn't matter how advanced our technology is if we cannot find the patients who could benefit from them. So to me, that means that really having a broader understanding of epilepsy in general will allow us to find those people. And then, of course, we also have up-to-date medications and so on and so forth. But it's really more important to have an understanding of epilepsy itself. So I want to talk about just some very basic medical management of seizures. I will not go over all the 37 different seizure medications. That's its own discussion. But I think what's really helpful is to figure out how do you work up the first seizure, if someone comes to you with a first seizure, and also to get a hint of who is someone who might develop refractory epilepsy, tough to control epilepsy, because those are often patients who may benefit from some of those more advanced treatments, such as epilepsy surgery. And that in and of itself is a multidisciplinary evaluation. And I wanted to go very quickly and briefly over some of those aspects because some of those aspects will also be discussed in my colleague Dr. Goldstein's talk. Next slide, please. First of all, some definitions and concepts. Now, one of the greatest misunderstandings that people have about seizures or epilepsy is that a seizure disorder and epilepsy are two entirely different things, whereas, truthfully speaking, they are the same thing. What it really means is that you have had at least one seizure and you are statistically likely, which is of course a very vague term which I'll get into more in more detail, you are more likely to have additional seizures, especially without treatment. However, there is this perception in the community that a seizure disorder is something that can happen in healthy children, it's going to go away, versus epilepsy is something that is associated with severe developmental disability. It's that kid in the wheelchair, it's that kid who was sent to, especially in the case of grandparents, it's a relative who was sent to an institution. That is what they think of when they hear the word epilepsy. And therefore, if you diagnose their child with epilepsy, of course, it is incredibly stressful for the family because they think that there is this full connotation of the word, which there doesn't actually really exist in a medical sense, but exists more kind of in the popular understanding. There's also a concept of whether seizures are provoked or unprovoked. And the idea is that can we clearly decide, is this something, a seizure, which was caused by abnormal brain electricity, was that caused by something that we can identify? So for example, if you have really high or low blood sugar and you have a seizure that is secondary to that we would not necessarily consider an epileptic seizure. You can have, or if, for example, the very common pediatric syndrome of febrile seizures, we don't necessarily consider that a seizure disorder or epilepsy. Or if in the acute phase of stroke, if you have a stroke that's related to the ongoing neuronal damage and death that's happening, we don't necessarily consider that epilepsy. You can develop epilepsy after any of these injuries. If you injure your brain, you can have seizures afterwards, you can have epilepsy or seizure disorder afterwards. But in that acute time phase, we don't necessarily consider that a seizure disorder. It just may develop into a seizure disorder. That seems like hair splitting, but after a single seizure, you have to think, is this something that's provoked? Is this something that's provoked and acute? Or is this something where it is really the sign, the first of many future seizures? And that's where the difficulty comes in, because we think if this is the sign of that this is the first of many, then the question of treatment becomes really important. versus watchful waiting, because we don't want to overtreat, we don't want to undertreat. Next slide, please. So what do we say is epilepsy or seizure disorder? This definition itself is changing somewhat. We used to say that it is 2 or more unprovoked seizures, or it could mean a single seizure, which the statistically high chance of recurrence. Well, what does that mean? So we have found that, there are certain risk factors that if you've had a single seizure and you have certain risk factors, your chance of seizure recurrence is much higher than that of the general population. Now, the usual numbers, the gross numbers that I give to a family, is that about 1 in 10 people in the general population will have a single seizure in their lifetime. That can be from any reason. That can be a febrile seizure. For example, it can be in New Orleans, at the time of Mardi Gras. I remember hearing from some of my attendings that you have to stock up on midazolam because everyone would drink too much and have their first seizure. Or, something like that. You can always have a single seizure. But then you do a thoughtful workup to help you figure out, do you have risk factors for seizure recurrence, which would mean that you might want to start treating after that first seizure. And we've found that those risk factors for seizure recurrence are, and they seem honestly fairly common sense. If you have an abnormal EEG study, if you have what we call an epileptogenic structural lesion, or if you have a strong family history of seizures and epilepsy. Now, the epileptogenic structural lesion, of course, that can cover a number of things. That can be due to an injury such as a stroke or non-accidental trauma. That can be something that is developmental or genetic, such as a condition such as tuberous sclerosis, where you just have abnormal folds in the brain, which can lead to seizures. But there are also things in the brain where, things in an MRI report where you can say there's, a subtle change in the white matter where you wouldn't say that would definitely cause epilepsy. So not every abnormality in the brain will lead to epilepsy, but there's certain ones, particularly the ones that involve the cortex, where the neurons are, where the thinking cells of the brain are. Those are more likely to cause seizures. Next slide, please. So, to get on the same page as a lot of families when it comes to epilepsy, I sometimes find it's really helpful to break it down into a very basic definition, because there's a lot of things that are called seizures which are not epileptic seizures or electrical seizures the way that we think of it. For example, the non-epileptic or psychiatric-related seizures are called seizures. Or you can have syncope, or you can have convulsive syncope, where it's a syncopal event where you have some jerking, but it's called a seizure. When we think of an epileptic seizure, we are talking an electrical abnormality of the brain, and that's what I like to make sure is clear to families. What happens is that you have abnormally synchronous firing of neurons that either may or may not cause actual physical symptoms that we can see. And there are 2 very broad categories of that. One of that is what we used to call focal. Every couple of years, we get together and we change the names of everything, but to use kind of the very commonly used terms, a focal seizure, very naturally, it's where you have a very localized regional electrical abnormality, which then may or may not spread to involve more and more parts of the brain. The other type is what we call generalized, where we think that essentially all portions of the brain get involved in the electrical abnormality simultaneously. And that's usually because they got a simultaneous or near simultaneous signal that was routed through the thalamus deep in the brain. It's sort of like getting a signal from Grand Central Station. So these are the 2 very broad categories of seizures. But the thing is, there's a lot of terminology out there, especially floating out the community, which is a little bit vague, and these are important because they tell you a little bit about what kind of medications may or may not work well for them, or whether they might be surgical candidates or for what kind of procedure. But you'll hear a lot of people describe petit mal seizures or grand mal seizures, and quite frankly, those terms could describe either different forms of either focal seizures or generalized seizures. So when someone comes to me and says, I saw it was a grand mal seizure, that could be anything, or it was a petit mal seizure, that could be anything too. Next slide, please. Now, what's really important is that again, this is really important that we are trying always to do better at treating this. And that's because these are both very common and they can cause a significant amount of social disruption, not just medical comorbidities, but social comorbidities that can, especially in the pediatric population, can last them their entire life. I always think of, for example, absence seizures, the so-called petit mal seizures. All you do is stare, and maybe you're called inattentive in class. And some families might think that, well, they never convulse, so what's the point of treating that? Well, we know that it can shave 20 points off your IQ if you don't treat that, even if they never have a convulsion. And another thing that we have to watch out for is that this also can affect your ability to drive, to be employed. So these have long-term consequences on your adult life. And it's common, about 1 in 26, so about 1 in 10 people will have one seizure in their lifetime, but about this 1 in 26, or 1 in 4, 4% of the population will have multiple seizures in their lifetime, have a diagnosis of epilepsy. Again, that doesn't mean a lifelong diagnosis, but it means that at some point in their life they had frequent enough seizures to have a diagnosis of epilepsy. And 10% of all seizures occur in children under the age of 3. So this is something that you will definitely see in babies, and we are also learning that again, the earlier we intervene, the better the outcome. Next slide, please. Okay, so, well, as we said, it's really important to figure out, when do we think seizures are going to recur when someone comes to us with a first seizure? So we have again identified some more of those risk factors. We talked about an abnormal EEG and so on. But there are other risk factors that we have found that are not quite so straightforward. For example, if you have on testing abnormal electricity, or on an MRI you have some sort of brain lesion, that's kind of obvious. But the risk factors of recurrence that we are finding as well is that if you are very young, so under age 3, or over age 10, you are more likely to have longer lasting seizures. Now, why might that be? Often it's when children present with seizures in those first few years of life, there's often, and this kind of ties into the second point of symptomatic cause, this is often due to some sort of injury or genetic cause. For example, children with a genetic disorder, which includes seizures as one of its symptoms, they often present over age 3, and if it's a genetic cause, that can be somewhat tougher to control than if it's another cause. And as for why children over 10, there are some age-dependent seizure syndromes that show up only in teenagers. And the ones that show up for the first time in teenagers, just the natural history of the age-dependent seizures that show up in teenagers, they just tend to last longer, and they tend to recur. There are certain ones that age-dependent seizure disorders that show up in grade school kids, which may have very few seizures or may generally tend to remit by puberty. But the ones that start at puberty or later, they tend to last longer. And another risk factor would be, again, that symptomatic cause. Is it genetic? Or was it prematurity? Was it a difficult delivery with hypoxic ischemic encephalopathy? Was there non-accidental trauma? All of these symptomatic causes which cause a structural injury to the brain. If you have this lifelong injury to the brain, you just have a higher risk of this injury leading to abnormal electrical patterns, which can lead to a seizure. As opposed to some children who are developmentally normal, you scan them, you do everything, and it all looks normal. Those people are somewhat less likely to have recurrence of their seizures. And those, patients where we don't know why they have seizures. They're developmentally normal, their MRI is normal, why do they have seizures? So our so-called idiopathic or cryptogenic kids. The kids that we find have recurrence of seizures, they often have an abnormal EEG, so that's why we do it, or they primarily have seizures during their sleep. And that's also sometimes related with some of those age-dependent seizure syndromes, such as benign Rolandic epilepsy, which is a syndrome of grade school kids where they tend to have convulsive seizures during sleep, but it is something that usually remits by puberty. But again, that is a pattern where they often have recurrent seizures, And so that's an example of, if you see seizures during sleep, those are often signs of a seizure syndrome, which may have recurrence. Next slide, please. Now, what's interesting about pediatric epilepsy as opposed to adult epilepsy is that epilepsy constitutes about 50% of a child neurologist's work, but only about 10% of an adult neurologist's work. So your average child neurologist has to be, by definition, more comfortable with epilepsy than your average adult neurologist. And part of that is that adults who have epilepsy, it's often due to tumors, accidents, trauma, things like that, versus a pediatric population who has epilepsy. It's genetic causes, it's prematurity, it's difficulty in the delivery with hypoxic ischemic encephalopathy. We have all these very pediatric-specific risks that lead to the childhood onset of epilepsy. And, especially when it comes to a child's brain versus an adult brain, 5 years makes a big difference in what your brain's doing. The brain of a newborn versus the brain of a 5, 10, 15-year-old are also different, versus the brain of a 40-year-old versus a 45-year-old. Hopefully there isn't too much difference, but that can vary. And that means that the actual effects of the various medications that we use, or the targets, they change, and that can be that means that you have to very much tailor your response to the whole clinical history of the child, which again can be very complex. In addition to that, one of the arguments that happens pretty much every year at the American Epilepsy Society is do we treat the seizures that children have when they have hypoxic ischemic encephalopathy and are in the NICU? Because we just talked about that. Well, symptomatic seizures, acute seizures that are happening due to an ongoing brain injury, they aren't really epilepsy. It's only if it's kind of persisting, that's when we worry about epilepsy. And then some people say, well, if we're throwing out phenobarbital and all sorts of, medications that themselves have serious effect on neuronal signaling, neuronal plasticity, are we actually causing iatrogenic harm by treating these seizures, especially in this neonatal period? Or even if you say a 8-year-old, if you put them on a medication, what kind of effect are we, if we have them if we have these children on medications from a young age, are we treating something to their benefit, or are we adding on a risk factor for abnormal neurodevelopment as well? And also, if you think about the volume of distribution for kids changes significantly for age. If you think about, a fat baby, and you think about a lean teenage athlete, and you think about our medications which are protein bound and how you dose them by weight, the way that we consider medications is different for infants than older children or teenagers or adults as well. And as I mentioned earlier, there are different goals of treatment at different ages. In a teenager, for example, control of seizures allows them to be able to drive, to play sports, to join the military if they want. There are rules about that. For example, how long you have to be seizure-free. If they want to become a pilot, if they want to become a truck driver, all of these things can be affected by how well you are able to control their seizures. Or even something as simple as, can I go to another town to go to college? Because if I can't drive and I have uncontrolled seizures, that may limit kind of your next steps after high school. Or, for example, it can be something even as simple as, is it safe for my child to learn how to swim? Is it safe for my child to go to camp, to go over to the grandparents, to go to a sleepover? These are all questions that I get asked, and they are related to how well you can treat their epilepsy. Or also, if your medication makes you sleep all day, then it doesn't matter that the seizures that were keeping them from learning are under control. Then they are asleep all day from medication side effects, and they still aren't learning. Next slide, please. So, some essential workup and management for when they start and come to see you. I don't want to go, again, over specific medications, because I think that, that's its own discussion. But I think that especially when it comes to someone coming to you with a seizure, what's really important is that there are seizures and there are seizure mimics. And it's important to get a sense of how do we get the best possible history so we can figure out what we're dealing with, so that if it's epilepsy, we can figure out where to start. And if it's not epilepsy, we can get them to the right person who can help them, or we can reassure them appropriately, so on and so forth. Next slide, please. So here are some historical details you might be able to get out of a family, and I'm also going to give some additional questions that may help you figure out some of the details of this event that people are concerned was a seizure. So we sometimes talk about an aura, a seizure aura, which is essentially just a warning, whether it's a visual, they see something, they see static, or you can hear auditory. Sometimes they say, I hear a noise, or I hear a bell ringing, or I hear a buzzing. I think I meant to also say you can also sometimes smell things. Like it's usually something terrible, like burning tires, burning plastic. Unfortunately, it seems that these auras are never something pleasant smelling. It's always something really disgusting. Or what we call psychic auras. Sometimes you get the sudden feeling of fear. I actually saw a kid the other day where his seizure aura was a feeling of fear, and the medications had controlled all his convulsions, but he was just getting this sudden explosive fear, which didn't feel good either. And why that's really clinically relevant is that if you have a specific symptom that leads into a clinical seizure, that itself is often the very first part of its seizure. That is abnormal electrical firing in a specific area of the brain, whether it's the auditory cortex, or it's near any of the sensory cortices or the motor cortex. And that tells you probably where the seizure's starting. That becomes relevant if we're considering the possibility of epilepsy surgery, because we need to know where the seizure starts before we can figure out whether surgery would be appropriate to stop it. But also sometimes that's also a really nice indication that we are probably dealing with a seizure. There are things that are not seizure, which can have kind of a warning, such as syncope. Sometimes, if you get the tunnel vision and you get cold sweats, that's its own warning that you're about to faint, but it's not quite the same as an epilepsy aura. But again, getting that history that, I get tunnel vision, I feel, my hands and feet start to tingle, I get cold and clammy. That warning that they get before they lose consciousness might point you towards syncope more than seizure, for example. So getting that, what kind of warning do you get before your event? Now, also very helpful when trying to figure out whether something is a seizure or not, especially when it's a baby. Because a family may come up to you and say, my baby had some event, they had full body shaking, or sometimes they'll say, I had a GTC, especially if they know somebody and know that kind of terminology. GTC stands for generalized tonic-clonic seizure. So what we think of the full body shaking type seizure. But, that can be a lot of different things, and not every full body shaking spell is a seizure. And also not every kind of motor seizure involving movement. Not every one of them is, again, generalized. It may start in a hand and then kind of move to the shoulder, the arm, the leg, and then the full body starts convulsing. But if you walk in at the very end where the full body's convulsing, you may not know that it really started with hand twitching. And that's often the case sometimes with the first seizure, where the parents didn't know anything was wrong until they heard knocking, or they heard someone fall, or they heard something like that. But if the family's able to tell you, it's always one arm that's shaking, or it's always one side of their face shaking, or they always look in one direction, even if they're not sure which direction it is, that's really pointing strongly to, that sounds like that could be an electrical seizure coming from a very specific part of the brain. If all they can say is it was full body shaking, then you still have a lot of questions to ask before you can be sure, is this a seizure or not? And also, sometimes if they say, oh, well, she stares off and she's unresponsive. Not all of, it's a petit mal seizure, they will say that's a petit mal seizure, or that's an absent seizure, and that's not necessarily true. Loss of awareness or responsiveness, that can be either a focal seizure or a generalized seizure. When it's a generalized seizure, that's what we call absent seizures, or what they used to call petit mal seizures. Those tend to be short. They last usually 5 to 10 seconds, and they snap right out of it very quickly, and they usually don't get any warning. And they also don't fall usually. So if it's very short and they go in, they go out, and that's it, that's, for example, a staring spell that could be a generalized seizure. However, if they say, she just stares off and it lasts for 90 seconds, that's less likely to be what we call a generalized seizure, an absent seizure. That may be a kind of focal seizure, and usually if they stare off during a focal seizure, it involves the temporal lobe. So that's a very different type of seizure. You don't do surgery for absence seizures, but you might be able to do surgery for a staring spell that comes from an absence, from the temporal lobe. And so that's why not just taking them at the word that, oh, it was a generalized convulsion, or oh, it's a petit mal, staring spell. Getting those additional details makes a big difference. Next slide, please. Now, I included this slide because I've also found that it's very helpful that if you hear that one of your patients has a seizure, when should you actually be calling, your local child neurologist or your local ER as soon as possible? So here is, some reassurance you can also give families as well. As I said, about 10% of people have one seizure in their lifetime, and about 60 to 70% of those don't develop recurrent seizures. They don't develop epilepsy. The ones where you say, this is very concerning and I need to have them seen by a child neurologist extremely urgently, calling, trying to get urgent, expedited, maybe even transfer over to be admitted, there's a couple of things that really worry us. Especially in very young children, under the age of 1, if we're not sure what's going on, we'd rather look and make sure that we're not missing anything. Even if it's reflux, I would rather know that for sure than to miss a potentially damaging early seizure disorder. And the early damaging seizure disorder that we are most worried about is something that's called infantile spasms. And that is an uncommon and unusual type of seizures, which can look like hiccups, they can look like belly crunches, they can look like sudden startles, and that is a specific type of seizure which can be neurodegenerative if it's untreated. You can start off with a healthy baby, and they will developmentally regress, and they will go on to they very frequently go on to have intractable epilepsy, often developmental delays, mental retardation as it used to be called, cognitive disabilities, all of those things, and we know that they have the best outcomes if they are treated very quickly. So if you have an infant between about, usually it's about 6 months, but it's happened as early as 2 months, but especially the classic story is about a 6-month-old who is developing these hiccuping or crunching movements that are happening in clusters, especially right around the time that they fall asleep or wake up. That is something where you should be calling, the on-call or, urgently, messaging a physician or a neurologist to figure out, is the story concerning? Because if they are in Seattle, often we try and admit them so that we can confirm this diagnosis and start treatment. Or if necessary, we want to get them in for evaluation as soon as possible, within the days to maybe a week at most, for best outcome. These are things that are often subtle, and it's hiccuping, or it looks like an exaggerated moral reflex or something like that. And sometimes it's really very tragic when I hear, oh yes, this has been going on for 6 to 9 months. We thought it was nothing, and now they aren't sitting up, they aren't holding their head up anymore, and this is happening all the time. And that's just very common because, again, it doesn't look like what people think of as a seizure. So if someone tells you, my baby is doing exaggerated startles over and over again, that's when we consider that an emergency, and that's something where please call us sooner rather than later. Or if you say, well, this is some sort of event and it's happening infrequently, then often we have time to kind of figure out what's going on. But if something is happening and it's accelerating in frequency, it's happening more and more often, whatever it is, we should probably figure out what it is because it's happening more often. So please feel free to make that more urgent referral. Now, on the flip side, what might we have more time for a more thoughtful evaluation, a less urgent assessment by a neurologist? Especially if it's been long-standing without any sort of developmental regression, then that tells us that whatever's going on, it does not seem to be affecting how your brain is functioning. It gives us a little bit more time to think, should we do the EEG first or the MRI first? Can that be done as an outpatient? Or if you have events where there's no loss of consciousness and you have complete awareness, there are certain types of seizures where that is true. You don't always have to lose awareness with a seizure. But if it's more like I stood up really quickly and I felt a little lightheaded and I thought I was going to faint and I sat down and I felt better, that is both something where you didn't lose consciousness, it was provoked by a positional change, and it kind of quickly resolved as soon as you changed position. Those are some signs that, this is something that is probably less acute, and we can be more thoughtful, and it may not be a seizure at all. Other things is that also sometimes I found that, especially when trying to get a family history of seizures, grandma had seizures. Well, what were her seizures like? Oh, she had them always when she was stressed out. That may or may not be a family history of epileptic seizures. Next slide, please. All right, so here's your workup. Here's what we can do to try and figure things out. So getting that history, cell phone videos, they are a game changer. What is your child doing? If they can show you a video, you can get the historical details yourself. You don't have to worry about trying to ask a terrified family member, while your child was turning blue, which way were their eyes deviated? That's the last thing on their mind. So if you can get a cell phone video, if it was a single event or especially recurrent events. Also, getting a careful birth history and a developmental history matter. If this is a child where you already have developmental delays and now they're doing something unusual that looks like seizure, your worry is a little bit higher than if you have a developmentally normal child who had no kind of birth injury that we are concerned about. Then you feel you have a little bit more time. Then you do a physical exam. What you're looking for are neurological focal findings, a weak arm, difficulty with head control, anything like that, clumsiness, a clear early-handedness, will this baby only grab, a toy with one hand? Then the next test that you do would be an EEG. We want to get awake and asleep because those are two different states. And as we mentioned, seizures during sleep or electrical abnormalities during sleep can be a risk factor for recurrence. So if possible, we like to get sleep. So we often, in children who are old enough to be sleep deprived, then we sleep deprive them. And then often we ask for an MRI of the brain. Not always, and if you're ever not sure, should I order an MRI of the brain or not, then you can always call and say, I know I have to get an EEG, but do I have to rush and get this child an MRI? Please feel free to call. Next slide, please. So you can actually get history from a kid if they're old enough to tell you this, or if they are developmentally able to tell you this. So sometimes, you can ask them, what do you remember? What do you remember? When did you wake up? What was the last thing you remember? There's going to be some amnesia around the time of a convulsive seizure with loss of consciousness. They may not remember everything up until the minute that they had a seizure, and they may only remember things that, oh, I woke up in the ambulance. And again, getting back to an aura, you can sometimes ask, did you, feel strange before it happened? And there's can be a number of different things that they'll tell you. But if they can say, yeah, I always know when this weird thing is going to happen, that is, that's potentially a useful sign. And another thing to often ask is, did you hurt yourself? Did you fall? Did you bite your tongue? And it's usually with seizures, they usually bite the side of their tongue because it gets caught between their molars. It's not usually the tip of the tongue. So sometimes if you're doing a physical exam right after a seizure, you want to open them up and look at the side of the tongue because it's sort of, you lose tone and your jaw muscles tighten up and then you catch the side of your tongue. Then, you can ask the questions. Do you have a video or can you get a video of the next event, especially if it's happened a couple times and they're coming to you because it's happened a couple times. Then, again, some of these historical details. What were they doing at the time? Were they active and all of a sudden they stopped and they stared? Or were they sitting in the backseat of the car during a long car ride and they were staring out the window and you talked to them and they didn't answer right away? Or they were playing a video game, you called to them and they didn't answer you right away. That's a slightly different, clinical scenario. Also, were they awake or were they asleep? This is also especially important when it comes to things like benign sleep myoclonus, night terrors, things like that. Because if they were asleep, did it actually seem to wake them up, or was it, right after my child falls asleep, their limbs just twitch a little bit, but it never wakes them up? Then that could be something else. Or if they were awake, for example, my child was awake when this happens. Do they actually stop what they're doing in the middle of it, or did they keep doing what they're doing in the middle of it? When it comes to auras, sometimes in kids who are nonverbal, if my child always seems really upset and comes to me and clings to me and then goes into an event, that sounds like maybe they get a warning and they're scared and they go to their parents. That's not unique to seizures. You can also get that actually with pediatric migraine. They start to feel dizzy, they start to feel nauseated, they seek out their parent, but that means something is warning them that something is about to happen. And also, is this something that kind of slowly comes on, or does it suddenly come on? You ask about provoking factors and how quickly they seem to recover from it. As I mentioned, absent seizures, you often recover very quickly, but that same sort of staring spell, which comes from a temporal lobe seizure, they have a postictal period, where, again, they can be groggy or confused or take a while to kind of come back to their baseline. So some of these histories of how they return to their baseline are helpful. Next slide. Oh, thank you. So when do you refer to neurology? Focal features to their seizure. One hand shakes, one side of their face shakes. They have, an abnormal physical exam where one hand or they have a facial droop. They have poor head control. Their development is not normal. All of these things, abnormal exam, of course, feel free to send them to neurology. Because again, you can have perfectly healthy, perfectly developmentally normal exam children who have seizures as well. But again, it's kind of common sense, an abnormal exam, or this, history which has, there's some sort of single place where seizures start, then definitely feel free to send them our way. If you have a strong family history, again, that sounds like it could be genetic and that could be complicated. Please feel free to send it our way. If they have developmental delay, or if you look at them and you're like this, and sometimes I have to ask, who in your family does this child look like? Because sometimes I say, you don't look like mom, but they're like, oh, it looks like, Uncle Herb. It looks just like Uncle Herb, and you're like, okay, maybe this is just, how this kiddo, the kid looks like their relatives, but sometimes not. Sometimes they say, my child doesn't look like anyone in the family. So that's, sometimes really useful, especially when it comes to soft findings such as prominent ears, Or obviously, if they have an abnormal EEG or MRI, that's a good time to do a referral. Next slide, please. This I'm going to go over really quickly, but these are kind of common sense things that might lead you to do some genetic testing, dysmorphic features, movement disorders, if they have a lot of birthmarks, which might make you think that they could have a so-called neurocutaneous disorder, if they have a really strong family history of epilepsy, or, you're like, I thought that this was going to be really straightforward. This is benign Rolandic epilepsy or childhood absent epilepsy, and none of the meds are working. This is really strange. If it's refractory and we have no idea why, of course, please feel free to, that is someone who might have an underlying genetic disorder that we should be considering. Next slide, please. All right, so for the last couple of minutes, or at least, I want to also talk about some of these really common questions that come up and have a very brief lead into some of the things that we do to evaluate a patient for refractory epilepsy and epilepsy surgery. So these are some common questions I get from providers about our co-managed patients who have epilepsy. If your child has ADHD or depression, there is often concern that starting a medication for that will lower their seizure threshold. And I've had some families say we couldn't start it until we had a chance to talk to the neurologist. From my perspective, those are medical conditions that need to be treated, and it is my job as the neurologist to adjust their seizure medicine so that they can get medical treatment for their needs. For example, antibiotics cause decreased seizure threshold, and I'm never going to say don't treat their pneumonia because it could cause a seizure. That would be bad medical care. So again, ADHD, depression, what have you, please feel free to treat it. And if you are concerned that they are having an uptick in seizures due to the medications that are on, then that's my job to deal with. In people who are on combined oral contraceptives, some of our anti-epileptic medications, in particular lamotrigine, can have interactions that it can make one or the other less efficacious. And again, that is my job to do more regular testing or to make a dose adjustment. Most medications have twice daily dosing. If you're over 16, then there are some FDA-approved once daily dosing. Allergies usually are rash, edema, and usually I like to see eosinophilia, because sometimes, I've had some things called a drug rash, and none of their lab testing supported kind of the systemic allergic reaction. And it went away, you stopped the medication and it went away. Was that just the rash going away on its own, or was it a true drug rash that was resolving? And sometimes if you don't do any kind of supportive testing, it's really hard to know, and sometimes that means, oh, we stopped a medication that was effective, and if it's a true allergy, we have to, but sometimes it's a coincidental rash. Here's another really good one. If your patient has missed less than 1 week of their medication, they can just restart it. If it's been longer than a week, then they have to go back up on the slow titration to restart it again. So roughly 1 week is kind of that magic cutoff of, oh, we went on vacation, or they admitted they haven't been taking their meds, or they were at their dad's house or their grandparents' house and they weren't getting their meds. Next slide, please. All right, very briefly, seizure rescue medications. Most seizures stop on their own in 2 to 3 minutes. Now, that feels like a lifetime and a nightmare for families, especially because children often, they have foaming at the mouth, they will have abrupt, facial cyanosis. Parents think their children are dying. So it is not very comforting to them to say, oh, it lasted for 2 minutes, this is fine, it'll end on its own. But also sometimes, again, some of the reassurance of during a seizure this may happen. This is kind of a seizure safety, a safe position you can put your child. This is how you can support your child. And even things such as, it's normal after a seizure for your child to be tired and confused and groggy, because sometimes it's a concern of, is the seizure going on still? Or, is something else terribly wrong going on because my child had a seizure and is still so tired and confused afterwards? We have the seizure rescue medicines for seizures or clusters of seizures, and usually the cutoff we use is about 5 minutes. And that's not because something terrible and life-threatening is going to happen at 6 minutes. Usually, we have our diagnosis of status epilepticus, or prolonged seizures that we think can be either threatening from a cardiopulmonary standpoint or can cause neuronal damage. Usually that we say is about 20 to 30 minutes. So the 5-minute reason is that there is always a distribution of how long seizures last. If the average is about 2 to 3 minutes, once you get past 5 minutes, you're really getting into the tail end of how long seizures last. This is an uncommonly long seizure, and it is more likely to continue on to that 20 minutes, that 30 minutes, that 60 minutes, that 2 hours, what have you. So we say 5 minutes we think is early enough where you can predict that this is a longer than usual seizure, and it's probably a good idea to work on stopping it. Now, it is not like a EpiPen where you have to get a medicine in seconds or something terrible will happen. Most of these medications are either rectal, intranasal, buccal, or ODTs. There are supply chain issues with all of them currently. They are generally benzodiazepines. Now, if you have a child who has complex epilepsy, they may have their own special rescue, but most of the time you will see it as some sort of intranasal or rectal or buccal benzodiazepine to be given for seizures that last longer than 5 minutes. Next slide, please. This is why I'm not going to, unfortunately, go into all the different seizure medications. Like many of the other specialties discussed, we have had an explosion of options. And definitely the older generation, the tried and true, they work very well. And sometimes that's what we have to go to. But we have a wide variety of ones where we can actually have fewer side effects and they're better tolerated, and we don't think that we have the long-term issues of causing, again, iatrogenic harm from medication side effects. Anything that acts on the brain acts on the brain. And so anything that controls seizures can make you fatigue, can give you, word-finding difficulties, can, alter your sleep, can do a number of different things. Next slide, please. I'm going to very quickly talk about CBD. CBD is a medication, but it's not a wonder drug. If someone wants to use it first, if they come in with a single seizure and they want to use CBD, I wouldn't recommend it, because the types of seizures that CBD tends to work on are in children who have a rare genetic disorder called Dravet syndrome, or people who have another terrible seizure disorder with multiple types of seizures, often daily seizures, called Lennox-Gastaut syndrome. So it probably works for more types of seizures, but I would say it probably works best on refractory, tough-to-control seizures and not just used as a first line. Next slide, please. So all of the studies, they are very useful, but again, it's for very specific diagnoses and also for very specific types of seizures. The types of seizures that CBD works best on are called drop seizures, where you can have just a quick drop of your head or fall suddenly to the ground. CBD works great on those, and cannabidiol works great for that. Cannabidiol is an anticonvulsant. THC is proconvulsant. I've had some teenagers, bless their heart, who think that because they're on Epidiolex, they can vape THC and have a seizure as a result. Unfortunately, it doesn't work that way. THC is bad for your seizures. Next slide, please. All right, now this is really important, I think, as a lead-in to the next talk that we're going to have. What is refractory or intractable epilepsy? Simple definition, and actually this is also evolving too. It is continued seizures after adequate trials, and it used to be after 2 appropriately chosen and tolerated medications. So adequate trials is you actually got up to a therapeutic dose, had therapeutic levels, and you watched it long enough to see does it work or not. If you tried a low dose of something and you stopped it after 2 weeks because of side effects, that's not really a full trial where you can say this is this is a patient who is, quote, you saying someone has failed a medication is not great terminology, but that's what we use. Also appropriately chosen, there are those 2 types of seizures, focal versus generalized. If you pick the wrong kind of medication, it may not work and it may actually make your seizures worse. Next slide, please. So how do we come to that definition? We find that if you have seizures, about 70% of people will respond to the first medication you use. It doesn't matter what it is. But after that, your chances of seizure control drop precipitously. And we also know that there's this prolonged impact of uncontrolled seizures. And so now we are actually discovering that we should consider epilepsy surgery early for these refractory seizures. And that is what the next talk is largely going to be about. I have some pictures, but honestly, they're probably better pictures that Dr. Goldstein has. But this is, and actually very recently we have information that if you have failed your first medication, the chance that you will fail your second medication is actually quite high, higher than we thought. So now we're starting to think maybe we should be thinking about trying to find the right candidates for epilepsy surgery after failing the first medication.